I have some practice questions for you. They are very easy, but I think just to give an idea of wording and whatnot. They are not at-risk questions. They are normal pregnancy questions. So I thought that was normal labor questions. And then I want your team to win, whoever your team is. So, okay. The other thing I decided to do, because I realize as I'm talking so fast, that when I have clinical examples, sometimes I don't get all the details, or I go so fast maybe folks don't know what that detail was and have a hard time getting that. So I've put some preterm labor and some preeclampsia scenarios up here just to kind of give us some talking points. I would not really stress about these particular scenarios, like I just made them up 15 minutes ago out of the top of my head. And so if you have questions or they trigger a question for you, I'm happy to entertain that. So since we did preterm labor yesterday, let's go ahead and knock these out. So preterm labor patient number 1, can you all see? Okay. This is a 29-year-old gravida 2 para 0 who's 30 weeks and 1 day. She's been contracting every 3 to 7 minutes, mild, no loss of fluid is what that abbreviation means. So bag of water is intact. Her badge exam is closed, long, and high. So even though she's contracting, we don't really have a lot in her history that says, preterm labor. So turbulene times 1 in an IV fluid bolus. So my question to you is the fetal heart rate. Do we measure the fetal heart rate at 30 weeks? Do we put it on the monitor? We do. But we may not get a reactive non-stress test. So I'm not really too alarmed by that if I don't get a reactive non-stress test. The main thing is I just want to get a good tracing. I want to make sure the baby's not having big B cells or anything like that. But as long as the baseline is somewhere between 110, 160, I see, decent variability, I'm okay with that. If this stops the contractions, which for many women it does, we send her home and we just do that expectant management. So we just do a lot of teaching with her. Okay. So the question came up yesterday about turbulene short term versus long term. And again, it's just me kind of going too fast. Turbulene, we used to give it in injections, and we also used to give it in PO form to OB patients. We don't really do that anymore because we have better medications now to treat patients. So when I say turbulene short term, we might use it once or maybe one more time, but we don't keep people on it for the management of preterm labor. We usually only give like a shot, maybe once of turbulene or twice, but then we start NAG if the patient's still contracting. The new medication that we tend to put people on long term is Procardia. Okay, so this is a different patient. 21-year-old gravida 5 para 3, or TPAL is 0212. So right away, there's some data there for you that should raise your red flags because she's had a history of a preterm delivery twice. So she is 32 weeks and she's been complaining of contractions all day. Notice her contractions are very similar to our first patient. 3 to 7 minutes, 30 seconds, and mild. Remember with preterm, we're not gonna be like, ooh, this is latent phase, ooh, this is active phase. We don't do that with preterm because preterm is any contraction or bad contraction. Okay, so I'm not really stressed about what phase of labor she's in because the other thing is if she moves toward delivery, she'll go through those phases super fast. Now, her badge exam is 1, long, and high. She also has not had loss of fluid. We did turbulene times 1. We got IV fluid started. They went ahead and did our cultures, and her fetal fibronectin was positive. More data that says, okay. So her cervix isn't too bad. I mean, it doesn't look like delivery's imminent, but because of the history of the fetal fibronectin, we're gonna go ahead and admit her. Her fetal heart rate is fine. The contractions have decreased in frequency and intensity from the TURB, but she still has 3 contractions in 30 minutes. The physician's probably gonna order mag sulfate. So your homework yesterday was to think about therapeutic effects of mag sulfate. And we need to kind of break this in half a little bit because we kind of need to talk about it from a preterm labor standpoint and then a preeclampsia standpoint. So what's your therapeutic effect with mag sulfate for preterm labor? What do you want to see? No contractions. Anything patients get it, okay? There was some thought that patients who got MAG for preterm labor, that it might be neuroprotective for the baby, and that the baby neurologically might do a little bit better. Again, just kind of depended on how much MAG the patient was on, what gestation, a lot of different things. But the main reason we give it for preterm labor is to stop contractions. So our side effects for MAG, let's do mild side effects first. Flushing. What's that? Okay. What's what? Muscle weakness. Fatigue. You feel hot. Pretty normal. You may get kind of, this is kind of sluggish, okay, kind of same thing. We get into toxicity. What are some toxicity signs of mag sulfate? And so often what we see with this is they're very hyporeflexic. We do not have to put a patient and dangle their legs to check their patellar reflexes. You can do that in bed. So the patient's in bed, you just kind of support underneath the popliteal space, and then you just tap beneath the patella, and you'll see that reflex. And so in this particular situation, the patient doesn't have any reflexes. That would be concerning to me. What other side effects what other toxicity symptoms of MAG can occur? Oh, what? What? Dysrhythmias. Please don't judge my spelling. Yes? Hypermagnesia. Okay. Magnesia. So in my domain, I don't recall what magnesium level is in med-surg land, but in my OB mind, for magnesium, I tend to think somewhere in the neighborhood of like 4 to 6 or 4 to 7, something like that. And there's not a lot of wiggle room. I think that's higher than what it is in adult land. And so with this, we often see like MAG levels of like 7 and greater, which would be a lab value. Decreased urinary output, because you don't excrete it in the kidneys. And so these are probably, so as a nurse, I'm probably watching for these things the most. And then if I see those things, then I would get a lab value to check this, and then I'm using calcium gluconate here for toxicity. So why do I bring this up right now? It's because I just want to point out that decreased urinary output is a sign of magnesium toxicity. We also see decreased urinary output with preeclampsia. And so we have to be careful, because sometimes we're looking at something to see if it's a side effect of a medication, when in fact it may be what the patient has been at baseline. So I'm always getting that baseline data first, because I want to know what I started from before I institute a treatment or procedure, and then I want to know what I'm looking for to see if it's improving, or hopefully maybe staying the same and not worsening, if that makes sense. Okay. All right, we're going to come back to preeclampsia in just a little bit. Multiples, has anybody had a twin delivery? Yes.
I was on Mother Baby, so I didn't.
And so was there anything different on Mother Baby? Just 2 babies, or?
A boy and a girl.
Mm-hmm.
And, they were pretty good size at both.
Did mom have any complications from the twin delivery?
No.
Is a badge delivery? Okay.
Actually an elective C-section.
Okay.
because as I was reading through her chart, it said elective. But then I saw one of the babies was breech, so I'm thinking her previous two births were vaginal.
Mhm.
Why would they give that elective if it was breech?
Well, the problem is, it depends on who's baby A and baby B. So baby A is usually the first one in the pelvis, and it may have been that baby A was breech, and they couldn't turn baby A, because you can't do a version with multiples. But she has a proven pelvis, and so maybe they were concerned that if they tried to deliver baby A vaginally, that it might cause a cord prolapse or something with baby B. So that's probably the big thing with multiples, is they can both be vaginal, they can both be C-section, but you could also have one vaginal and one C-section. So multiples have more complications. They usually are seen more frequently. Like if you have a patient having twins, you'll see that patient more in the office. So all of these conditions that we've talked about, a patient's more at risk of when they have multiples. We wanna make sure they're gaining enough weight. Like I mentioned before, they're often on so they might take 2 prenatal vitamins. We want their weight gain to be greater because they're growing 2 babies. They'll do serial ultrasounds, again, monitoring the amniotic fluid and the growth of the baby. There are sometimes some odd conditions that can develop with a twin pregnancy. You could have a condition called twin-to-twin transfusion. You could have one twin who is growing really well and the other twin is struggling. And so there's often a decision made, sometimes based on the baby who's struggling, that maybe we can do more for that baby in NICU. You have to monitor, with twins, you will monitor the babies separately. And so what will happen is you will see, you'll have contractions here, and then you'll have one baby's heart rate, and then you'll have another baby's heart rate. And then you may also see mom's heart rate. Mom's heart rate tends to have less variability, and mom's heart rate hopefully is not between 110 and 160. That would be a little bit high. But you don't have exactly the same tracing. Now with triplets, they usually don't necessarily monitor the triplets all at the same time, so sometimes they'll move them around about who they're tracing. Typically, once they get a reactive NST on one baby, then they'll move to the other baby. But again, it can be pretty challenging. I have only seen twins induced. I've never seen triplets induced. And to the best of my knowledge, I do not know of any vaginal triplets, at least here locally. So you might ask your clinical instructors if they have seen that. I have not here. I do know folks in other parts of the country have had vaginal triplets before. But here we tend to do a lot of C-sections because of risk or complications. Some of our hospitals, you actually don't deliver in your labor room, so you labor in your labor room, but when it comes time for delivery, they actually make you deliver in the OR vaginally, and it's because if they need to go up quickly to a C-section, that they can easily make that, there's not having to move you from the labor room to the OR. And the other thing is, for these patients, they have a really distended uterus because they had 2 babies in there, so they are high risk of postpartum hemorrhage after delivery. So they may need multiple interventions beyond Pitocin. So when talking about multiples, we've already kind of talked a little bit about C-section already, and this is kind of the same list that we had before. In terms of pre-op care, the big thing is that your patient, we make sure we get consent signs, bracelets are signed. We'll do our routine labs. It's also, you might have a type-in screen or a type-in cross because of the concern about more blood loss with a C-section. If the patient's had a history of a hemorrhage with a previous delivery and she's gonna be a repeat C-section, they usually go ahead and have either 2 units or 4 units of packed red blood cells ready to go that can be administered if needed during surgery. Intraoperatively, when we take the patient into the OR, we note the time that she comes into the room, we note the time that anesthesia is started, we note the time of the first cut, you wanna note the time of the delivery, the time of the placenta, and then also when you close each layer. And count should be done as you close each layer to make sure they are correct. Intraoperatively, there might be a lot of verbal orders. It's very common for the patient to get antibiotic after the baby's been delivered. And then also after the baby's delivered, they may give mom a little bit of extra medication. So it's not uncommon if mom's real anxious or nervous that she might get a little bit of Versed on the table. Postoperatively, we're watching very carefully for hemorrhage. If you were to ask me as a labor and delivery nurse, what's my priority in the PACU, post-anesthesia care unit, number one is bleeding, because not only can you bleed from the incision, but you can bleed from your lochia, okay? I get infection, I really do. Infection is a key concept, but we tend to have bleeding show up first. Bleeding shows up first. The signs of infection, it takes, if you think about the stages of wound healing, the first thing that should happen is vasoconstriction to stop the bleeding, and then you have the inflammatory phase take place. So you'll have an increase in white blood cells, but we're not gonna see fever, we shouldn't see fever, drainage from the wound, purulent drainage, foul odor, things like that in the recovery room. If I see a change in the patient's temperature in the recovery room, I tend to think it's more related to perfusion or a side effect from anesthesia than infection. But again, it depends. If your patient had chorioamnionitis, does everybody know what that is? Chorioamnionitis. So chorioamnionitis, it's basically an infection inside the uterus while she's pregnant. After she delivers, we talk about endometritis, but a lot of times in practice in the hospital, we use shorthand and we just say she has chorio. So they'll say, oh, the patient has chorio, and that means there's infection in the uterus. All right, so on to preeclampsia. With preeclampsia, we talked about the symptoms, so tell me what the symptoms of preeclampsia are. You did that last time.
Severe headache.
What's that?
Severe headache.
Severe headache. Maybe, sometimes diaphoresis is actually normal in labor, especially because you're hearing that extra fluid. Blurred vision, I would say these are severe, absolutely.
Your blood pressure.
So high blood pressure, or some, protein in the urine, that's a big one. So protein in the urine, blood pressure, headache, edema. Edema is kind of one of those funny ones because sometimes women have edema that's normal in pregnancy. So we talked about normal edema, that it's in your legs after you've been on your feet all day, and then you lay down, and then in the morning it gets better. These are folks, they get swelling everywhere. So it's in their fingers, it's in their face. Anascara, does that ring a bell for you with generalized edema? Anascara, do you know that term?
I heard it, just can't remember.
Ah, darn medical terminology. I think I'm spelling it right. Anascara. Anascara?
It's like the eyes.
Anascara is generalized edema. You're thinking of scomata.
Oh.
Yes. So, the big thing about edema by itself doesn't mean you have preeclampsia. The other thing is just blood pressure by itself doesn't mean you have preeclampsia. So it's a cluster of symptoms together. And in this situation, the patient is very sick, because really the only, and I hesitate to say this, when a patient has severe preeclampsia, we have to deliver her. The delivery is not the cure, because she may still have preeclampsia after delivery, but it should make the trajectory of the illness start to go towards health rather than illness. So when a patient has preeclampsia and she's in the hospital, we are a lot more strict about what guidance we give her. So we'll keep her on bed rest. You want to decrease the amount of stimuli in the room, so we turn the TVs off, the lights are dim. You don't want people coming in and arguing over rent and who's going to pay the car payment, because it just stresses moms out. And that stress is irritating to the CNS system, and the whole thing about preeclampsia is seizures. And they come about from, again, the CNS miscommunication. So there's irritability in the CNS. Now, with hypertension, I mentioned this the other day, in med-surg land, hypertension, you often had fluid volume excess. So there's too much fluid in mom's system. And yes, in pregnancy, we are increasing the volume, so you would think it's the same thing. But actually in preeclampsia, what happens is the fluid leaks out of mom's vascular system around that, and that's where you get the generalized edema. The edema will put pressure on different things. It kind of causes the exacerbation of symptoms. So again, some of the headache and the seeing changes and things kind of comes about from cerebral edema. And again, for some patients, it's like it will come out of nowhere. Like they were fine, and then 2 days later, they got a washcloth in their eyes, and they're like, "Oh my gosh, I have the worst migraine ever." And that's probably the most common thing I've heard recently with young women is they think it's a migraine, so they downplay the symptoms. It's like, oh, it couldn't possibly be preeclampsia. The other thing is it's been in media more, so because it was in Downton and Abbey. The lady died in the show from preeclampsia. It's been in Call the Midwife. So I think people are seeing those shows in like Hollywood and stuff, and they're really scared by preeclampsia. So again, it is serious, and as a nurse, you need to, again, kind of keep your patient calm. And really the best thing for the patient is to be in the hospital so we can monitor her, because if her condition changes rapidly, then we can do something about it. Now, in the hospital, we generally will have a patient who's with severe preeclampsia on mag sulfate. And quite honestly, if the patient has severe preeclampsia, we tend to move toward delivery. We don't just kind of sit there and wait on it anymore. The other thing is mag sulfate, the reason we give this, and this is really important, the reason we give it is to prevent seizures. It's not to lower her blood pressure. There are other medications that actually lower her blood pressure better. So if she just has hypertension, they're probably gonna give her labetalol, which is a beta blocker. That's pretty effective. That's the one I'm the most familiar, that's the one I've seen the most, is labetalol. Apresilene can also be used for hypertensive crisis. With a patient who is on mag sulfate, it is critical as the nurse that you monitor the respiratory rate, urinary output. So this patient will be on hourly intake and output. So she may have a Foley catheter in place because we want to make sure the kidneys are perfused. You'll check her reflexes, and then you'll monitor the baby as well. Now with reflexes, it's really important to check those reflexes, but if she's hyperreflexic, meaning she's 4+, when we say 4+, what I mean by that is if you just barely tap, I mean, it's very visible. You barely touch the patient and they're hyperreflexic. We don't want to keep tapping those reflexes because we're causing that stimulation. It can actually precipitate seizure. So we institute seizure precautions. So you might pad the side rails. You want to make sure everything is cleared around the head of the bed. We don't want to put anything in the patient's mouth if she does have a seizure. You have suction set up at the bedside. You're kind of prepared for that. Most women do not seize, which is good, because when mom has a seizure, that's where fetal death occurs, and then also maternal death. With serum magnesium levels, again, I would say single digits are good, and I would say, again, kind of below 7 or so. But if the level gets high, you give calcium gluconate. I will tell you, the change in practice that I'm seeing, we're using a lot lower doses of mag for a shorter amount of time. And I think it's because we made moms really, really sick when we were given mag for a week straight, trying to treat preeclampsia. In some cases, the patient will be induced or augmented for labor. Now, the problem with that is when mom has preeclampsia, we have decreased volume, and so the perfusion to the baby is often affected, and so the baby may not tolerate labor very well. This is a baby who may be IUGR, SGA. You may see oligohydramnios as a result of preeclampsia. So with fetal monitoring, we want to make sure the baby tolerates that okay. The other thing is, just like mag makes mom feel kind of fatigued and weak, it also makes the baby feel fatigued and weak. So you'll notice a change in the baby's heart rate on the monitor. So you might go to minimal variability. We usually do not see D cells though, because the mag shouldn't be impairing perfusion. In fact, mag hopefully is helping improve perfusion. But again, it depends on how much mag the patient's getting. Very important to keep the patient comfortable. We would want to talk to the patient about our pain management options. Depending on her labs, she may or may not be a candidate for epidural. And remember, if you have preeclampsia, and we start to see your hemoglobin decreasing, your platelets decreasing, and you have elevated liver enzymes, you're getting super, super sick, and we need to go toward delivery. So that would probably be an emergency C-section. Now, during postpartum, it isn't that poof, magic, everything's better. And that's, I think, another thing that's been kind of a change in practice, because we used to always tell everybody, you'll feel so much better as soon as the baby delivers. And what we're finding now is that women are continuing to have preeclampsia 24 and 48 hours after delivery. So even on mother-baby, you need to watch the patient very carefully for symptoms of preeclampsia. And then in terms of in labor, one of the things that we would watch for is abruption. Abruption, and there's some pictures here that kind of show you the separation away from the separation of the placenta away from the uterus. And again, we see that with severe preeclampsia. Mild preeclampsia, usually not. But again, what would cue you in is significant abdominal pain. You may see tetany on the contraction pattern, where she has multiple contractions with no break whatsoever. And again, the baby tends to go into distress. And the concern with that is hemorrhage. And then DIC, disseminated intravascular coagulation. So it's this kind of very complex disease where you have a combination of you're bleeding, but you also are forming microclots at the same time. Your coag factors are very off. Again, usually for us, we're trying to stop the hemorrhaging. We suspect DIC when we start seeing blood from the IV site. She's bleeding from her nose, she's bleeding in the urine and the catheter. Her lochia is not stopping bleeding. She continues to ooze blood. And again, she's been preeclamptic or she has HELP, then we would suspect DIC. Sometimes DIC can occur on its own as well, but it's one of the cascades. It's a worsening of HELP. So cuvillaire uterus, this is again an unusual finding, but it's where we talked about where the uterus, the blood actually gets into the lining of the uterus and it looks blue in color. It should be pink in color, but when you do a C-section and you see that, that's again a worrisome sign. And in some cases, the patient's hemorrhaging so much that they actually have to remove the uterus. Eclampsia. So with eclampsia, the patient's actually having a seizure. You want to stay with the patient, treat it as a medical emergency. Typically in OB, at least in our urban hospitals here in Louisville, we pretty much have everybody that we would call from a rapid response situation. But if you don't have everybody, you could call rapid response or code team to come and assist you. But anesthesia comes, OB comes, you want the code card. Usually we go ahead and activate NICU as well, because we're usually gonna move toward delivery. And so that's one of the things about the case study. In the case study, they talk about that the patient has a seizure, and then they stop the seizure, and the OB determines that it's okay to just go ahead and proceed with labor. And that has not been my experience. My experience is once the patient has a seizure, they stop the seizure, but then we take her to the OR and we do an emergency C-section. So again, this all has to do with seizure precautions. It's not uncommon to see fetal bradycardia. It's depending on the length of the time of the seizure. You could also see hypoglycemia in mom. But again, my experience with this, it doesn't happen very often, but it is very scary, and we want to stop that seizure as quickly as possible. All right, so in talking about placenta problems, now preeclampsia doesn't make you have a previa, okay? A previa just happens as part of the kind of growth and development of the pregnancy. And some people are prone to them and other people aren't. So just because you have a previa with one pregnancy doesn't mean you're gonna keep having previas with subsequent pregnancies. Sometimes what happens is early in pregnancy, the patient will get an ultrasound and they will tell the patient that she has a previa or a partial previa. So the placenta is covering part of the cervical os, that's the cervix right there. Hopefully, as the pregnancy continues and it enlarges the uterus, the placenta will kind of slide out of the way so there's no blocking of the cervical os. Whereas a complete placenta previa, like in this situation, even as the uterus starts to grow, the placenta doesn't really have enough room to be able to move. So typically a complete previa, it will stay a previa, and so it's important to educate that patient during her pregnancy that she will likely be a C-section. And the other thing is, if you have a complete previa, we don't want you to labor. So if she starts going into labor, we definitely want to know about that. With previas, the classic symptom with a previa is painless, bright red bleeding, okay? Whereas with an abruption, sometimes with an abruption, you will see external bleeding, but sometimes it's internal bleeding. The whole thing about an abruption, it is painful. And an abruption can occur just from contractions. It can occur from a health condition like preeclampsia. It can occur from trauma. So like a car accident, domestic violence, drug use can set you up for abruption. So again, these are things that tend to contribute to issues with third trimester bleeding. So I mentioned a CREDA. I would not worry about an ACREDA, an INCREDA, and a PERCREDA. I would just know, again, an ACREDA. And I mentioned the ACREDA, you're more at risk of developing that when you have recurrent C-sections. And again, the placenta basically grows into the endometrial lining of the uterus, and it will not detach. There's no way to get it removed from the inside of the uterus. When a mom has this and we know about it, we are very prepared. There will typically be blood and it's on site. We may type and cross for more blood, so 6 or 8 units. And again, for a lot of patients, it will result in a hysterectomy. So it's helpful, we can see this on ultrasound, and again, if a patient's had prenatal care. Now, if a patient has not had prenatal care or I didn't have an ultrasound, how would I suspect this? The placenta does not detach. Remember, we talked about placentas, they should detach early express within a few minutes, but spontaneously 5 to 30 minutes. When you have a placenta that's staying in there longer than 30 minutes, that is very worrisome for vaginal delivery. And so with a manual removal of a placenta, the provider will put on sterile gloves, take the hand and go all the way up inside the uterus and try and detach and pull that placenta out. And when you kind of get up there and feel, there's nothing to loosen. It's so entrenched in the membranes of the uterus that you can't detach it. The other thing I have seen with retained placenta, sometimes if they suspect it or when they look at the placenta after delivery and they notice there's a piece of it missing, they'll do a quick bedside ultrasound and see if they can find it where it is in the uterus. They kind of know where to grab. So it's not just a blind sweep trying to look for that piece of placenta. Ultimately, again, if they can't get the retained placenta, they'll send the patient for D&C. A D&C would not work for an ACREDA because it's just that grown in. And again, there's not really anything you can do about it. There's nothing, you can stop it, there's no medicine to take, it just happens. So a vasoprevia, this is where the vessels kind of protrude in front of the presenting part. Sometimes there's an extra lobe of the placenta, and so there's actually membrane. Sometimes it almost looks like a jellyfish between the lobes of the placenta and those vessels. That's what vasa are in front of the presenting part. So obviously if you have something like this, the big concern there would be cord prolapse. All right, so this is a good chart. It strikes me as something that would lend itself well to a select all that apply. So distinguishing the difference between placenta previa and an abruption. So notice with previa, it's bright red bleeding and it's not associated with preeclampsia. The one thing I do want to bring up, when I say painless bleeding with a previa, the patient will still have pain if she's in labor, okay? But it's not like abruption pain, so that's a part to distinguish. Abruption pain is severe, it's usually right around the fundus, and it's constant. The abdomen is very hard, it feels like a board, and very rigid. So you don't have this palpation of the contractions easing and getting, mild, moderate, and strong. see that with abruption. In both cases, the patient can go into shock. And then the other thing is, with a previa, it can actually change the engagement and presentation of the baby, because the baby can't get down into the pelvis to get down to the ischial spines, the placenta's in the way. Okay. Is there any questions you have about placenta previa or abruption? So in talking about preeclampsia, again, the one thing we watch for is abruption. Now, after she delivers, abruption's not a risk. The placenta's gone, the baby's not in there. So abruption's really only a labor and delivery concern. Once she's delivered, that we don't worry about. Again, I would not get too stressed out about this. I just wanted to show you some other pictures of different types of placentas. Again, the placenta can give us a lot of really cool information about the pregnancy, about labor, and that's one of the reasons that we inspect it. So do not worry about these terms. I would not give you a picture or ask you to tell me the difference between those. I do think it's helpful if you have a delivery to be able to look at the placenta. Some are small, some are large, some have calcifications on the maternal side, some have short cords, some have long cords, they have a lot of Wharton's jelly, some are real skinny. So again, I would just kind of maybe take a peek and then move along on this slide, okay? You got enough to worry about. So we talked about operative vaginal delivery yesterday. And so with forceps and vacuum, that would be during what stage? 2. Wouldn't be any phase, because all the phases are in stage 1. So stage 2 of labor. It would not be in stage 3, because stage 3, the baby's already delivered. We're waiting on the placenta. Okay. The other thing about forceps and vacuum, it's not something the nurse does. It's applied by the provider. And I'm very concerned about the risk to the baby. I want to make sure the baby's okay. Mom is also more at risk for tearing, so she may have more pain and trauma. So I need to watch her carefully and make sure her pain is under control, and then a lot of swelling, pain, and edema in her bottom. So what do we do for patients right after delivery to help minimize pain and swelling in the perineum? Ice packs, those little chemical ice packs. So have you seen anybody, I hope the answer is no, have you seen anybody put like ice in a glove and put that up against the patient's bottom? Yes. So do you think there's some issues with that? Or do you think that's okay? What do you think? Like, why do we use the pricey chemical ice packs compared to just putting ice in a glove or ice in a diaper? So sometimes we'll see that. One of the things we have to be really careful about ice is good, but we can cause tissue damage if it's too cold for too long. And so those chemical ice packs will not get so cold that we hurt the patient. So I would just be real cautious about when you see nurses doing that kind of stuff. I get why they're doing that. You know, we talk a lot about like women when they have engorgement pain, like to use frozen peas, frozen vegetables, because it kind of shapes the breast and it's real, you know, comfortable. But we wouldn't want to put that directly on our skin. We want like just a light cloth there so we don't get, you know, any kind of skin damage from the application of ice. All right, OB emergencies. I don't know if I tell you what, before I go into this, let's do our let's do at least one of our preeclampsia scenarios. I'd like to finish up preeclampsia before I get into this, so. All right, so let's do this one. This one, okay. So preeclampsia, number 1, 18-year-old gravid 1, Para 0, 40 weeks. So she's young and it's her first baby. She's had increased blood pressure, edema, and headache the last 3 to 4 days. Her vag exam is 1, long, and high. So her Bishop score is high or low?
Low.
Low. Her Bishop score is low. So she's gonna need more intervention. She she would not be somebody I'd wanna start Pitocin on. Pitocin may make her have contractions, but her cervix is what we call, it's not favorable. She has a really long piece of balloon, okay? It's open, one finger, but we need to soften it, and it's her first baby, so we need to do some things there. So Cytotec is a cervical ripening agent, and so maybe they started it at 7 o'clock on Thursday, and then that can be repeated every 6 based on her contractions. So if she's not contracting, they might repeat that. Remember, it's a very small dose, 25 micrograms. It can be inserted vaginally, it can be sublingual, it can be rectal. They give Cytotec a lot of different ways. That's different than how we use Cytotec for postpartum hemorrhage. Based on this, she goes into labor from the Cytotec, and so she goes into labor on her own. We just let her labor, and she just kind of becomes kind of a normal labor patient. The baby, she's 40 weeks, which is term, so I'm not really too concerned about preterm. Baby will, should do okay. Now with the preeclampsia, there may be some perfusion issues. So during labor, one of the things I'm gonna watch for is what type of decel.
Variable.
Lates, I would say more lates, until maybe we break her water. And once we break her water, I'm thinking more variable. But I may not have any of those things, okay? Now, can she get an epidural? Is there anything there? There's nothing here that I see that says she wouldn't get an epidural. As the nurse, I would wanna talk and look at her CBC, so I would look at her white blood cells, hemoglobin hematica, and platelets. And that would cue me in as to whether, as long as her platelet count is okay, more than likely they would say she's fine to get an epidural. But based off what I see here, I don't see any red flags for that. When should she get her epidural? Should she get it Thursday night? Closer what? Usually we wait till there's kind of regular contraction patterns, and we're kind of committed to labor. And so again, the provider sometimes will say, we have to wait till you're 4 centimeters, or, but when she's kind of in labor, we know she's gonna go there and get the epidural in. So she has a vaginal delivery at 6 p.m. on Friday. Do you think that's a long labor or a short labor, considering we started Cytotec at 1900 the day before? So that was 23-hour induction.
Maybe long, but it's her first kid, so.
Long. So like if you were thinking about when did labor start, did it start back here or did it start here? I think I would go more from when contractions had started, because even when I give Cytotec, just because I give her Cytotec doesn't mean her labor has started right that minute. The first Cytotec, there may have been no contractions at all. So to me, labor starts with contractions. The other thing is, for this patient, they started MAG after delivery. So in other words, she had no MAG sulfate whatsoever during labor. Is that okay? Yes. And the reason why is sometimes they don't wanna give MAG during labor and delivery, because the preeclampsia is mild enough and we're going toward delivery, and they don't want the side effects of MAG affecting mom during labor and delivery, or affecting the baby. Okay? Any questions on this? This is a very common scenario, by the way. You'll see this a lot. And in some cases, they don't even do this. In some cases, they just watch, wait, and see. They send her to Mother Baby, and they'll say things like, they thought she had preeclampsia, but she's delivered. So out on Mother Baby, I'm gonna be checking her blood pressure, but I also want her to let me know if she has any visual changes, she's seeing spots, she notices her swelling getting worse. What happens on Mother Baby after you have a baby? You should diurese. You should be getting rid of fluid, so it should be diaphoretic, and you should be having tons of urine output because you're getting rid of that extra fluid. And in preeclampsia postpartum, they don't diurese, they don't get rid of that extra fluid. They actually get more swollen puppy. So, all right, let's go ahead and take a break.